Hello, my name is Dr. Craig Chepke. I'm the Medical Director of Excel Psychiatric Associates in Huntersville, North Carolina. I'm also an Adjunct Assistant Professor of Psychiatry at the University of North Carolina School of Medicine, as well as an Adjunct Associate Professor of Psychiatry at Atrium Health. Welcome to our expert-driven psychiatry case in movement disorders, presented by the Journal of Clinical Psychiatry. In order to discuss how we deal with drug-induced movement disorders in psychiatry, I'd like to introduce you to a patient of mine. His name is James, and he's a 50-year-old man with bipolar disorder. He was diagnosed initially when he was in the Army, which was one of his lifelong goals, and unfortunately he had a manic episode while serving that led to his medical discharge. So I started taking care of him about a year or two ago, but he's had a really complicated history prior to that. At the present time, his manic and depressive symptoms are pretty well controlled, but he still has some outbursts of anger occasionally. And if you ask James about his goals, the thing he says time and time again is that he just wants to have a normal life and just be able to be with his family. At James's most recent appointment, he came in and he was really upset. Apparently, he told me he was involved in some kind of altercation. He was at the grocery store and this other shopper came up to him out of nowhere and accosted him. He said that James was saying something about him under his breath, and James says he didn't do anything the like. He was livid at that kind of accusation, and his anger, he just exploded at that other customer. James was asked to leave the store. The manager even threatened to call the police. When I explored the incident with James, he said, "I was pissed about the incident with that guy saying I was talking trash. I mean, people say my lips and tongue are moving sometimes when I'm not talking, but wouldn't I know if my body was moving?" So at first, James said that he didn't notice that he was making the movements, but when I explored the topic with him a little bit more and asked him a few more questions, he does seem to have some insight into it. He told me, "I feel like a lot of people just look at my mouth when they speak to me and they don't even look me in the eye. I know it must be moving some weird way, so I try to stop it, but I don't think I can. Lately, even my family looks at me weird. You know, I love my family more than anything in the world, Doc, but I've been avoiding them since my cousin started calling me Mr. Wiggly Mouth at a cookout a few months ago, and everybody laughed at me." These symptoms can have some really profound effects on a patient's ability to engage in social situations and feel comfortable. So let's further investigate what could be going on here with James. James takes the atypical antipsychotic medication lurasidone 80 milligrams and also lithium 900 milligrams at bedtime, and I also prescribed him 1 milligram of lorazepam to help manage his anger episodes when they do happen. James is overweight, and he also has type 2 diabetes, for which he takes 1,000 milligrams of metformin daily. I also want to point out that he was hospitalized because of his bipolar disorder relatively early in the course, and at that time he had a manic episode which was treated with the first generation antipsychotic haloperidol, which was initiated at 5 milligrams twice daily, and he also was given quetiapine 300 milligrams at bedtime. During that hospitalization, he did experience some drug-induced Parkinsonism, and that was managed with benztropine. It was titrated eventually up to 2 milligrams twice daily, and that was continued over the course of about a year or a year and a half. When it was finally discontinued by a previous clinician, there was not a return of any drug-induced Parkinsonism. I want to point out that the discontinuation of benztropine could have occurred much earlier, and this may be a case where he didn't need to be on that medication nearly as long as he was, which is not consistent with the best practices. James also had another episode of abnormal movements several years after that first episode. He experienced what he described as tremors in his fingers and once again was prescribed benztropine. However, this time around, adding benztropine did not help James's symptoms, and so the clinician discontinued it. As a next step, they tried decreasing the dosage of lurasidone down from 80 milligrams once daily to 60 milligrams a day. They continued that for a week and then further down titrated it to 40 milligrams once daily. Unfortunately, this not only didn't help, it actually seemed to make the movements a little bit worse. And on top of that, James also suffered a relapse of major depressive episode, and so he has to be put back on the former dosage of lurasidone. As we'll later see, reducing the dosage of the antipsychotic medication is not always best practice in some types of movement disorders, as some don't respond to that dose reduction and need to be managed as their own chronic condition. So looking at James's prior history, it's not surprising that he was really frustrated with this situation and didn't want to talk about it at all. He was just living in denial of it, really. He didn't discuss it again until that episode with the grocery store happened. So based on the information we've just discussed, we need to figure out what movement disorder James is experiencing. With his symptoms, we did not see the sustained muscle contraction that we would expect to see in dystonia. nor did we see the intense inner restlessness feeling that patients with akathisia have, nor the inability to sit still. Now, he did have a history of drug-induced Parkinsonism, so we need to consider a reemergence of those symptoms. However, this time around, he did not have any change in his antipsychotic or change in the dosage of his current one, and that makes it less likely. And furthermore, when he had drug-induced Parkinsonism in the past, benztropine did have a beneficial effect for him, but it did not this time around. So all of that would be speaking against the possibility of drug-induced Parkinsonism. One of the keys that I found to differential diagnosis of drug-induced movement disorders is matching up the characteristics of the symptoms with the timeframes of their onset. For instance, with dystonia, which is a sustained muscle contraction, almost always that's going to occur within the first 5 days of starting the treatment. Still early on, within the first week or so, would be akathesia. Akathesia is an intense internal sense of restlessness that's accompanied by the patient being physically unable to stay still. Within the first weeks to months after starting a new treatment or increasing the dose, we may see drug-induced Parkinsonism, and that it consists of a generalized bradykinesia, which is a slowness of movement and stiffness, but it may be accompanied by several focal areas of hyperkinetic movements, which are tremor in this case. And finally, we need to consider tardive dyskinesia or TD. TD starts months to even years after the antipsychotic is begun and consists of chorioathetoid types of movements. Dyskinesia can also occur after a dose reduction or stoppage of an antipsychotic, but if the symptoms resolved within 1 to 2 months after that, we consider that a withdrawal dyskinesia instead of tardive dyskinesia. However, because James's movement started with a stable dose of an antipsychotic, that was not a factor in his case. Other things we need to consider are that James has a mood disorder diagnosis, in this case bipolar disorder. He's also received a first-generation antipsychotic in his past, haloperidol, and that gives us another potential clue to the type of movement disorder that he has. Another consideration is that he was on benztropine for a prolonged period of time in the past, and long-term usage of anticholinergics can increase the risk of certain types of movement disorders. So based on what James has experienced, his risk factors, concomitant medications, the timing of symptoms, we can conclude that his symptoms are most suggestive of tardive dyskinesia. Tardive dyskinesia, or TD, is an involuntary movement disorder that occurs in association with any medication that blocks dopamine receptors. Most commonly, we're going to refer to those as antipsychotics, but other medications, such as certain gastrointestinal medications, can also block dopamine receptors. As I mentioned, we typically see TD occurring very late, which is actually where the name comes from. The tardive is the French word for late, like when my kids go to elementary school and they're tardy for their classes. The earliest we tend to see TD is after a few months of treatment, and oftentimes it's even years after starting the medication in some cases. The symptoms can even start after the patient has stopped the antipsychotic, as long as they persist past 1 to 2 months. There's just a lot of variability in tardive dyskinesia. The characteristics of TD are also distinct. They're non-rhythmic movements, unlike tremor, and they can range from writhing serpentine motions that we would call choreiform to faster tic-like athetoid movements. It's best practice to use standardized rating scales such as the AIMS, or the DISCUS if you prefer, every 6 months in patients who are high risk for tardive dyskinesia. For people who are not high risk, it should be at least 1 year per current guidelines, and that's for any patient taking any dopamine receptor blocker, such as any antipsychotic. In both the AIMS and the DISCUS, individual body regions are rated from a scale of 0 to 4, where 0 means there is no movement that's involuntary, 1 is potential involuntary movements, but they could be on the extreme range of normal, and then 2, 3, and 4 going from mild, moderate to severe confirmed dyskinetic movements. As you can see from this diagram, really any part of the body can be affected by tardive dyskinesia. Importantly, it's not just the muscles that we can see, such as the arms, the lower extremities, the trunk, the muscles of facial expression, but also muscles we can't see. The esophagus, the diaphragm, and other muscles internally can also be affected by TD as well, and these can result in potential real-world consequences for these patients. It's important to screen every patient who's on an antipsychotic medication for TD. And when we talk about screening, we should be consistent with the American Psychiatric Association guidelines. And what they recommend is the usage of those standardized rating scales. However, we need to go beyond that. And also in 2020, an expert consensus group used a Delphi method to achieve some other recommendations for TD, which state that we should be doing brief semi-structured exams on patients with antipsychotic treatment, even between those structured examinations. That means at least thinking about TD in every visit with every patient on any antipsychotic. These would be used to supplement those rigid, formalized screening tools. And as you can see, some of the elements we capture in the Ames exam would rate involuntary movements in the muscles of facial expression, movements of the lips, tongue, the upper limbs, the lower extremities, and then the neck and trunk. However, we have to move our thought process from thinking about the severity of TD as being the sum of those 7 first items in the Ames to a more modern approach where we look at items 9 and 10, the patient's awareness of the movements and their incapacitation due to those movements. Ames is nothing but a number, I like to say, and it's more important to think about how TD is impacting the patient's function and their quality of life. But in order to be able to find out if a patient is aware of their movements and how they're affecting the patient's functionality, we have to learn how to ask them the right questions. This is not something that we've typically been taught how to do in mental health, so there's a lot to consider here that we have to think about. So now that we've made the diagnosis of tardive dyskinesia for James, what do we do about it? The answer to this question has really changed over time. The old gold standard used to be discontinuation of the antipsychotic, or at least lowering the dose or switching to a lower potency agent. However, we now know that that is not really the best approach for probably most patients with TD. We have data and also clinical experience that confirms that TD is generally persistent for almost all patients. What stopping the antipsychotic does do, however, is to increase the risk that they're going to relapse and have a worsening of their psychiatric symptoms. For James specifically, we know that in the past when his medication did try to have a dose reduction, he had a very rapid return of more severe symptoms, so we don't want to do that to him again. What we do have today that we didn't used to have many years ago was the presence of 2 FDA-approved Vmat2 inhibitors that can be used in adults with tardive dyskinesia. Vmat2 stands for vesicular monoamine transporter type 2. This enables us to be able to modulate certain neurotransmitters, including dopamine, which is the key neurotransmitter implicated in the pathophysiology of TD. And these are able to reduce the symptom severity of tardive dyskinesia. The 2 medications have the names Deuterobenzene and valbenazine. Both have been found to be well tolerated and efficacious in managing the symptoms of TD, and they can do so without changing the patient's primary antipsychotic regimen. With valbenazine, we generally look at the CONNECT-3 phase 3 study that was a 6-week trial in adult patients with TD. They were required to remain on their current antipsychotic medication with no alterations. The investigators randomized patients to either placebo, valbenazine 40 milligrams daily, or valbenazine 80 milligrams daily. The primary outcome measure was the change from baseline to week 6 in the Ames dyskinesia score. What they observed was a 3.2-point reduction in the least squares mean with the 80 milligram dose, a 1.9-point reduction with the 40 milligram dose, and both of which were significantly greater than the 0.1-point reduction with placebo. Discontinuation due to adverse reactions was 5.3% on the placebo group, 5.6% on valbenazine 40 milligrams, and 6.3% on valbenazine 80 milligrams. Now, turning to take a look at deuterobenzene, there was a similar trial called the AIM-TD study that was also done in adults with tardive dyskinesia over a 12-week period. Once again, we see that their primary psychiatric regimen was continued unchanged. Randomization in this study consisted of placebo, deuterobenzene 12 milligrams, deuterobenzene 24 milligrams, or deuterobenzene 36 milligrams. However, it is important to note that these dosages of deuterobenzene that are mentioned were divided into 2 daily dosages. For example, the 36 milligram group, those patients took the 18 milligram dosage twice daily. The improvement in the Ames score in this study had a least squared mean reduction of 3.3 points from baseline at the 36 milligram dose and 2.1 points from baseline with the 24 milligram dose of deuterobenzene, both of which were significantly greater than the 1.7-point reduction from baseline in the placebo group. That's about a 2-point difference in the placebo and the 36 milligram treatment arm. Discontinuation due to adverse reactions here occurred in 3% on placebo, 5% on 12 milligrams a day, 3% on 24 milligrams a day, and 4% on 36 milligrams a day. With valbenazine, it's worth noting that we have a 1-year long-term extension study. This enabled us to see the long-term safety and durability of the effects of valbenazine up to week 48 with both the 40 and 80 milligram daily dosages. In the next episode, we're going to balance James's considerations and choose a Vmat2 inhibitor for him. What we really need to consider in the real-world treatment of patients with tardive dyskinesia are the intersection of the biological factors, psychological factors, and social factors. At the intersection of these factors is where we may see the real detriment to the quality of life and functioning outcomes that a patient with TD could experience. These can be difficult to measure, but it helps to know what kind of questions to ask for those domains. For instance, we might ask questions about their physical health, such as whether the patient chokes on food, bites their tongue or cheek, or has difficulty speaking or breathing. These are all real-world outcomes that I've seen in my patients with TD. We also need to consider asking about psychological factors, like feelings of embarrassment or distress, reluctance to go out in public. That's all part of the assessment we should be doing in every patient with TD. And finally, socially, does the patient have difficulty engaging in work or leisure activities because of their TD? It could have affected their relationships with their family, friends, or colleagues. These are questions we need to get used to learning how to ask and consider. For James, one of the keys to his treatment is that he really can't remember to take his medication more than once a day. So I've tailored his medications to make sure he takes it once a day at night. To maintain that kind of simple regimen for him, to make sure he's able to maintain adherence, we can add valbenazine, which is a once daily medication. Per the prescribing information, we started valbenazine at 40 milligrams once a day, which again, he took at bedtime, and then after 1 week, increased to 80 milligrams. It's important to discuss with your patients, like I did with James, some of the potential adverse effects that they might experience. For instance, that could be somnolence with valbenazine. Deuterobenzene has slightly different common adverse reactions, like nasopharyngitis and insomnia. And with both Vmat2 inhibitors, there is a risk of Parkinsonism, which is something that James experienced already in his past, so we need to be mindful of that. Now that we've initiated James on treatment with valbenazine, we need to talk about what's expected and how to monitor results. When we talk with patients about treatments in psychiatry, it's important to clarify the time frame in which they may expect to see results. Just as I do with SSRIs, I tell patients who are taking valbenazine or deuterobenzene that they need to be patient. For instance, I would say that you may see some benefit in the first few weeks, but you really need to give it at least 6 weeks to really see the full benefits of the treatment. In terms of monitoring, we're going to use the AIM score at baseline, and then after treatment has initiated, and then periodically throughout the treatment to be able to monitor your progress. Once again, James is a patient with bipolar disorder who also we've diagnosed with tardive dyskinesia, and we've begun treatment with valbenazine. Initially, we had titrated him up to 80 milligrams per the package insert, but despite having a good response in terms of his tardive dyskinesia, he did start to experience some Parkinsonism at that dose. We were able to manage that by reducing the dose of valbenazine to 60 milligrams a day. After that change was made, he no longer had the Parkinsonism, but he did remain well controlled in terms of his TD symptoms. So not only do we need to educate our patients on how to take the medication, we also need to set appropriate expectations in advance so they'll have the best chance of success. We also need to monitor them, not just for efficacy, but also for adverse events. So if any occur, we can manage those adverse events appropriately. The most important point to take away from today is that we need to screen every patient on every antipsychotic for TD and do so regularly. We need to do it both with standardized rating scales like the AIMS or the DISCUS, but also do it with semi-structured examinations in between those structured examinations. Because if we don't look for TD, we're never going to find it. We need to ask the right questions, not just ask, does it bother you? And then if the patient says no, to walk away from it. We need to ask questions about the biological impacts, psychological impacts, and social impacts to really tease out the functional and quality life impairments that TD can cause for many patients who suffer from it. And then once we determine that the patient has TD and that they are having some of these quality of life issues, we need to undertake the correct treatment. There's been a dramatic change in how we look at the treatment of tardive dyskinesia. For over 6 decades, all we really could do was try stopping the antipsychotic or reducing the dose, switching to a lower potency medication, and that just didn't seem to work for patients very well. TD is persistent in almost everyone, unfortunately, and we have to get used to this new paradigm. Previously, we had no proven safe and efficacious treatments. So if we did add on a specific medication, it was often an anticholinergic medication off-label. However, we know that anticholinergics actually worsen tardive dyskinesia and can increase the risk of TD in those who don't already have it. So we need to be much more judicious with the use of anticholinergic medications. And when we do add a medication, the Vmat2 inhibitors are proven safe and efficacious by the FDA. But 6 decades of muscle memory is hard to overcome. So we need to really think about what is the evidence basis behind the treatments that we're making and learn these new treatments for the betterment of our patients' outcomes. I want to thank everyone for joining us in this expert-driven psychiatry case. It's been a real pleasure to go through this data with you, and I hope that you can use it to better the outcomes for your patients.